This is our third lecture in Pharmacology 1, Pharmacology of Infectious Disease Agents. We're going to cover antibiotics and antivirals. So these are our objectives straight from the syllabus for antibiotics and antivirals. We want to differentiate and apply the therapeutic applications, routes of administration, mechanism of action, primary and significant adverse effects of these agents, recognize indications and contraindications of the selection of medications for the treatment of infectious diseases and their conditions, and then explain strategies for educating patients about antimicrobial therapy to promote adherence to treatment plans and support optimal management of infectious diseases. And these are the antibiotics and antivirals that we'll cover. So on the left, you see the list of antibiotics, and on the right, the list of antivirals. So before we look at specific antibiotics, we want to make sure that we're all using the same language. So let's talk about bactericidal versus bacteriostatic. Bactericidal antibiotics kill bacteria. Common examples include Beta-lactams, Vancomycin, and Fluoroquinolones. These are often preferred in severe infections or immunocompromised patients where we want rapid bacterial clearance. Bacteriostatic antibiotics, on the other hand, inhibit bacterial growth rather than directly killing the organism. Examples are tetracycline and macrolides. These rely on the patient's immune system to finish clearing the infection, and they're very effective in many common outpatient infections. And then next, let's look at broad versus narrow spectrum antibiotics. So a narrow spectrum antibiotic are preferred whenever possible because they target specific organisms and support good antibiotic stewardship. Broad spectrum antibiotics cover a wide range of organisms and are typically reserved for severe infections or situations where the pathogen is unknown, such as early sepsis. So anytime possible, we want to be choosing the narrowest effective antibiotic. That is one of the ways that we help prevent resistance. Okay, so here we're going to zoom out and look at our major mechanisms of action for antimicrobials. Almost every antibiotic fits into one of these three buckets. So first, our cell wall inhibitors. These include our beta-lactams and vancomycin. These drugs specifically interfere with bacterial cell wall synthesis, which causes the bacteria to lyse and die. Because humans don't have cell walls, this mechanism is very selective, and that's why many of these agents are bactericidal. Clinically, these are mainstays for serious infections like sepsis, pneumonia, skin infections. Secondary is protein synthesis inhibitors. This group includes macrolides, tetracyclines, clindamycin, and aminoglycosides. These drugs bind bacterial ribosomes and prevent protein production. Most are bacteriostatic, meaning that they stop growth rather than directly killing bacteria. Many, with aminoglycosides being a notable bactericidal exception in this group. And you'll see these used a lot for respiratory infections, atypical organisms, and skin and soft tissue infections. Third, we have the nucleic acid inhibitors. These are your fluoroquinolones, sulfonamides, antivirals. These agents interfere with DNA or RNA synthesis or function. Clinically very powerful, but they often come with important safety considerations, which is why appropriate indication and stewardship matter. So as you move forward, you want to be asking yourself what bacterial process is the drug targeting, and that helps you predict the effectiveness, the resistance, and the side effects. Okay, so let's look at our beta-lactams. These work by binding penicillin binding proteins, or PBPs. These are enzymes responsible for cross-linking peptidoglycan, which makes up the bacterial cell wall. PBPs are blocked. When they are blocked, cell wall synthesis stops. So the bacterial cell becomes structurally weak, and eventually the cell lyses or bursts. The end result is a bactericidal effect. Clinically, beta-lactams are going to work best against actively dividing bacteria because the cell wall synthesis is happening during division. These are especially effective against gram-positive organisms as they have very thick cell walls. Key resistance mechanism is beta-lactamase production. where bacteria break the beta-lactam ring and inactivate the drug. Clinical pearl for you is if a patient isn't improving on a penicillin, always consider beta-lactamase resistance and whether a beta-lactamase inhibitor might be needed. Okay, so vancomycin also targets the cell wall, but it works differently than the beta-lactams. Vancomycin binds directly to the D-ala terminal of peptidoglycan chains, which completely prevents cross-linking. So what this does is it leads to bactericidal cell death, making vancomycin bactericidal as well. Some of our differences from beta-lactams: vancomycin works only on gram-positive organisms, including MRSA. It is too large to penetrate the gram-negative outer membrane. Resistance occurs when bacteria change the binding site from D-ala to D-ala D-lac, and that prevents vancomycin from binding. So why does this matter clinically? Oral vancomycin treats C. difficile, for example, because it is not systemically absorbed and works locally in the GI tract. IV vancomycin is used for systemic infections like MRSA, osteomyelitis, endocarditis. So important administration pearl to remember. Oral vancomycin will never treat a systemic infection, so the route matters just as much as the drug. Okay, now let's talk about macrolides, which include azithromycin, clarithromycin, and erythromycin. Mechanism of action: the macrolides bind the 50S ribosomal subunit, which we have heard about before. By doing this, they block the translocation step during protein synthesis. So when translocation is blocked, the ribosomes can't move along the mRNA, so protein elongation stops. What this does is overall effect is bacteriostatic, meaning these drugs inhibit bacterial growth. At high doses, they can become bactericidal. So but in general, you want to think of a macrolide as static. Clinically, macrolides are especially important because they cover our atypical organisms. So that includes organisms like Mycoplasma, Chlamydia, Legionella. This is why they're commonly used in conditions like community-acquired pneumonia, where atypicals are commonly a concern. Important safety consideration is macrolides carry a risk of QT prolongation due to their effect on cardiac ion channels. So clinically, we want to be cautious in patients with known prolonged QT, electrolyte abnormalities, or those taking other QT prolonging medications. So those are drug-drug interactions. If you see, so clinical pearl, if you see pneumonia plus concern for an atypical, think macrolide coverage, but you always want to do a quick QT risk check before prescribing these medications. Tetracyclines, with doxycycline being the key example. Mechanism of action is tetracyclines bind the 30S ribosomal unit. By doing this, they prevent the attachment of tRNA, which blocks protein initiation. So if the bacteria can't start making proteins, it cannot grow. The result is tetracyclines are bacteriostatic, so they inhibit bacterial growth rather than directly killing the bacteria. Clinically, doxycycline has broad coverage, so it covers gram-positive organisms, gram-negative organisms, atypicals, and even MRSA, which is why you'll see it used often for things like community-acquired pneumonia, skin infections, tick-borne diseases. A important pearl is that doxycycline interacts with calcium and iron, which decreases its absorption. So patients should not take it at the same time as dairy products, antacids, calcium or iron supplements. Finally, tetracycline needs to be avoided in children under 8 years old and during pregnancy due to the effects of teeth discoloration and the effects on bone development. That is a high yield point, often asked on exams, and obviously important for clinical practice. So clindamycin works by binding the 50S ribosomal subunit. This blocks peptide bound formation. In other words, the bacteria can't string amino acids together, so protein synthesis is disrupted. The result, of course, is bacteriostatic, so it's inhibiting the bacterial growth rather than directly killing the organism. However, clindamycin is very useful against toxin-producing organisms because stopping protein synthesis also stops toxin production. Clinically, clindamycin, very good anaerobic coverage and strong gram-positive coverage, which makes it useful for skin and soft tissue infections, dental infections, certain necrotizing infections when combined with other medications. So big caution with clindamycin, very high yield. This carries a high risk of C. difficile infection. It significantly disrupts our normal gut flora. So patients with diarrhea during or after treatment should be evaluated promptly for C. difficile. This is a great example of a drug that is effective, but has to be prescribed very thoughtfully with precautions and patient education. Aminoglycosides, specifically gentamicin and tobramycin. Mechanism-wise, aminoglycosides bind the 30S ribosomal unit. This causes misreading of mRNA, which leads to the production of dysfunctional proteins. So these abnormal proteins disrupt the bacterial cell, also generate oxidative stress, which contributes to cell death. So the result is aminoglycosides are bactericidal, which is unique because most of our protein synthesis inhibitors, as we said, are bacteriostatic. Clinically, these drugs work well. Strong gram-negative coverage, including serious infections caused by organisms like Pseudomonas. They're often used in combination with beta-lactams because of synergistic effects. So beta-lactams weaken the cell wall, allowing the aminoglycoside to enter more easily. Toxicity is a major limitation for this class. Aminoglycosides carry significant risk of ototoxicity and nephrotoxicity, so drug levels and renal function must be monitored closely. Clinically, we want to think of aminoglycosides as very powerful, short-term agents for severe gram-negative infections, effective but not forgiving if we misuse them. Fluoroquinolones, including ciprofloxacin and levofloxacin. Mechanism of action is inhibition of bacterial DNA replication. They block the DNA gyrase, also known as topoisomerase II and topoisomerase IV. By doing this, they prevent bacterial DNA from unwinding, which ultimately halts the DNA replication. So because of that, they are bactericidal. Clinically, fluoroquinolones are considered broad-spectrum antibiotics. They cover gram-positive, gram-negative, and atypicals, which is why they are very appealing choices, especially if we don't know the exact pathogen. This class has some important and serious adverse effects. There is a risk of tendon rupture after use, so we have to be cautious with patients that are highly active and even elderly patients if they are, have a risk for this. QT prolongation, peripheral neuropathy. Because of these risks and FDA warnings, we have more recently reserved fluoroquinolones for severe infections or situation where a safer alternative is not appropriate. So clinically, we think of these as broad coverage, not always first line. Fluoroquinolones are very powerful, but they have to be used sparingly. Sulfonamides, specifically trimethoprim sulfamethoxazole. We have a two-part mechanism in folate synthesis. So the sulfamethoxazole blocks dihydropteropate synthase, and the trimethoprim blocks dihydrofolate reductase. By blocking both of these steps in the folate pathway, bacteria can't produce folate, which is what they need to make DNA. Without DNA synthesis, bacterial replication stops. As a result, the two together are bactericidal, even though each drug alone is bacteriostatic. So this is a synergistic antibiotic therapy. This is always given together. Clinically, this combination, trimethoprim sulfamethoxazole, is highly effective for MRSA skin infections and uncomplicated UTIs. So very commonly used in outpatient medication choice. Safety considerations, there is risk of hyperkalemia and rash, should be avoided in pregnancy. It also has significant drug interaction with warfarin, so it increases our INR and our bleeding risk. When prescribing trimethoprim, sulfamethoxazole, always think about potassium levels and medication interactions, especially our older patients or patients on anticoagulants. Introducing our common antivirals and separating them by the viruses they treat and their mechanism. So first, our herpes antivirals like Acyclovir and Valacyclovir. These are nucleoside analogs. They get incorporated into the viral DNA and cause chain termination, which means the virus cannot continue replicating its DNA. The end result is viral DNA replication stops. Clinically, these are used for HSV and herpes simplex virus and varicella zoster virus. They work best when started early in an outbreak. Next are the influenza antivirals, specifically Oseltamivir and Zanamivir. These are neuraminidase inhibitors. They block the release of new viral particles from infected cells. The result is shortened symptom duration and reduced viral spread, but they do not cure the flu instantly. So timing really matters here. They are most effective when started within 48 hours of symptom onset. So key takeaway for antivirals is they don't kill viruses outright. They limit the replication and spread, allowing the immune system to clear the infection. So we've got a nice table here that summarizes our coverage for gram-positives, gram-negatives, and atypicals among the classes we just discussed. And again, just a summary slide, bugs versus drugs. So this is just kind of going through our most common conditions seen in PA practice. So strep throat, we're generally using penicillin or amoxicillin. Cellulitis, cephalexin or clindamycin. Atypical pneumonia, you're going to use your macrolides or doxycycline. And then UTIs is nitrofurantoin, which we didn't talk about, trimethoprim or fosfomycin, and then C. diff is oral vancomycin. So what are some of our big principles in antibiotic stewardship? We always want to use the narrowest spectrum possible. We want to avoid unnecessary broad spectrum coverage when we do not need it. So broad spectrum coverage is generally if we have a very early sepsis or a very early serious infection and we do not know the pathogen. Whenever possible, we match the drug to the bug we are treating. So culture when appropriate to get, actual documented matching. We want to avoid treating viral infections with antibiotics, and this will come up again and again. We'll talk about this more when we go through ENT. And of course, we're going to use these for the shortest effective duration. These are some CDC resources that I pulled that are very helpful with discussing, the antibiotic stewardship. And also when you get these encounters with patients that want antibiotics for viral infections, these are good patient education handouts, but this is information you should be able to discuss without any resources. So you should know all of this information. This will come up again and again in clinical practice. So please review these, make sure you understand how we're counseling the patients when we talk about antibiotic use and acute infections. Okay, so we're going to dive in a little more to our cell wall inhibitors, our beta-lactams and vancomycin. So first, our beta-lactams. This class includes penicillins, cephalosporins, carbapenems, and monobactams, and their mechanism of action is to inhibit bacterial cell wall synthesis by binding those penicillin-binding proteins. Let's zoom in on our penicillins, very common class. So first, our natural penicillins, that's Pen-VK and penicillin G. These primarily target Streptococcus species, so think classic strep infections. Next are the aminopenicillins, amoxicillin and ampicillin. These expand coverage compared to the natural penicillins by adding limited gram-negative activity, which is why amoxicillin is so commonly used for things like otitis media and sinusitis. Then we have anti-staphylococcal penicillins. So this includes dicloxacillin and nafcillin. These are designed to resist penicillinase and are used for MSSA, methicillin susceptible Staph aureus, but not MRSA. So the key takeaway here is the spectrum. Natural penicillins cover strep. Aminopenicillins broaden coverage slightly to gram-negative organisms, while anti-staphylococcal agents specifically target staph. So this reinforces why choosing the right penicillin depends on knowing the organism and the resistance pattern. So let's look a little more closely at the spectrum of activity for penicillins, meaning what they're good at covering and what they're not good at. So penicillins are good for, they have strong activity against Streptococcus species, which is why penicillins are often first line for things like strep pharyngitis when resistance is not a concern. They are also effective for syphilis, specifically penicillin G, which remains the treatment of choice. This is a classic board question in Clinical Pearl. Penicillins also cover actinomyces, another gram-positive organism you'll see in chronic oral or cervicofacial infections. Now, what are penicillins not good for? They do not cover MRSA. So if MRSA is in your differential, you need to choose another agent. They do not cover atypical organisms like Mycoplasma, Chlamydia, because those lack typical cell wall structures. And then penicillins are not reliable for most gram-negative rods, especially the more resistant hospital organisms. So when you're using penicillins, you're going to think strong strep coverage, limited reach beyond that unless the drug is combined with another agent or modified. Amoxicillin and ampicillin, which are both aminopenicillins, very commonly used in primary care. First, looking at uses. These drugs are frequently prescribed for otitis media, sinusitis, and strep throat. They are also important because they are considered a pregnancy-safe option for UTIs, which makes them especially useful in the OB setting. Adverse effects, most commonly, you will see rash and diarrhea. These are usually mild and are self-limited, but important to warn patients about them so that patients are not unnecessarily concerned or stopping the medication. Contraindications, obviously penicillin allergy. A key point here is that not all reported penicillin allergies are true allergies. You want to always clarify whether the reaction is a true IgE-mediated reaction like hives, angioedema, anaphylaxis, or is it more of an intolerance such as GI upset? A very high yield pearl, an amoxicillin rash in the setting of infectious mononucleosis is common and is not a true allergy. The patient is not allergic to penicillin or the penicillin class, even though it may be labeled as such. So always clarifying allergy history before avoiding beta-lactams. Doing so can significantly expand the number of safe and effective antibiotic options that your patient has. Extended spectrum penicillins, which are penicillins designed to overcome resistance and broaden coverage. So first, amoxicillin clavulanate, also known as Augmentin. So here, clavulanate is a beta-lactamase inhibitor. Its role is not to kill bacteria directly, but to protect amoxicillin from being broken down by beta-lactamase enzymes. So that is how it expands the coverage. Clinically, Augmentin is used for dog and cat bites, sinusitis, and treatment-resistant otitis media, situations where you're worried about beta-lactamase producing organisms. Clavulanate, when you're counseling patients, clavulanate significantly increases the risk of GI side effects, especially diarrhea. So patients should be warned about this upfront so they do not stop taking the medication unnecessarily. Taking with food can help. Patients can also sometimes use antidiarrheal agents. Next is piperacillin tazobactam or Zosyn. This is a broad spectrum IV penicillin paired with beta-lactamase inhibitor. Primarily, this is used in the hospital setting. Zosyn is important because it covers serious hospital-acquired infection, including Pseudomonas. Not an outpatient or routine infection drug. It's reserved for very sick patients and high-risk infections. So adding a beta-lactamase inhibitor helps extend coverage, but it also comes with more side effects and stewardship considerations. Cephalosporins are a major beta-lactam class, and the generations are very high yield for exam and clinical reasoning. First generation cephalexin. Think strong gram-positive coverage, especially skin and soft tissue infections. Second generation is cefuroximine, and there are other examples in these classes. I'm giving you one or two examples that are the most common. So cefuroximine, this adds a bit more gram-negative coverage compared to the first generation. Third generation, ceftriaxone, cefdinir. These are commonly used clinically. Ceftriaxone is IV or IM and is used for pneumonia, sepsis, meningitis. Cefdinir is oral and often used outpatient. Fourth generation, cefepime, this is very broad coverage, has strong gram-negative coverage, including Pseudomonas. So the takeaway here is that as we go up in the generations, you get increased gram-negative coverage. So remember, earlier generations are better for gram-positive organisms. Later generations shift toward gram-negative coverage, and with very few exceptions, cephalosporins do not cover MRSA. Looking more closely at our first generation cephalosporins. Most common agents you'll see are cephalexin and cefazolin. Cephalexin is oral, while cefazolin is IV. In terms of use, these are great for skin and soft tissue infections, especially cellulitis. Cefazolin is also the go-to agent for surgical prophylaxis, which is a very high yield clinical question. First generation cephalosporins can be used as an alternative for strep pharyngitis, particularly in patients who can't take penicillin. Adverse effects most commonly to remember are GI upset and rash. There is rare cross-reactivity with penicillin allergy, but this is much lower than people think, but you will hear about it on the board exams constantly. Clinical pearl, if a patient reports a vague penicillin reaction, first generation cephalosporins like cephalexin can still be a safe option. But again, we always want to clarify that allergy history before prescribing. Second generation cephalosporin common agents are cefuroximine, cefaclor, and the cefamycin, cefatin, and cefotetin. In terms of use, second generation cephalosporins are commonly used for sinusitis, otitis media, community-acquired pneumonia, also useful for skin and soft tissue infections. The cefamycins, cefotoxin, and cefotetin are especially important because they offer intra-abdominal infection coverage. So cefotetin you will also hear used for surgical prophylaxis for that reason. Adverse effects, most patients will probably have mild GI upset or rash, similar to our other cephalosporins. A couple of high yield pearls for cefotetin is it can cause a disulfiram-like reaction. So that is when patients take alcohol while using the medication and they get GI upset, vomiting, flushing. It can also increase bleeding risk due to the risk of hypoprothrombonemia. So when you see a question about intra-abdominal infection or surgical prophylaxis with a second generation cephalosporin, you're thinking of cefoxitin or cefotetin, and remember those unique adverse effects. Third generation cephalosporins you will use a lot clinically. Common agents here are ceftriaxone, ceftazidime, and cefdinir. Third generation cephalosporins commonly used for community-acquired pneumonia. Ceftriaxone is especially important because it is first line for gonorrhea. It is also widely used for meningitis due to its excellent central nervous system penetration. This generation is also used for complicated gram-negative infections. So one key distinction in this class is ceftazidime is a third-generation cephalosporin that does cover Pseudomonas, which is high yield for exams and clinical decision-making. Adverse effects most commonly are GI upset. One critical safety pearl is that ceftriaxone has to be avoided in neonates due to the risk of kernicterus from bilirubin displacement. And then finally, remember that C. diff risk applies to the entire cephalosporin class, including third generation agents. So think of your third generation cephalosporins when you need strong gram-negative coverage with reliable systemic penetration, including central nervous system for ceftriaxone. Moving right along to fourth generation cephalosporins, the key drug is cefepime. Cefepime is reserved for severe or resistant infections. So not a routine outpatient antibiotic. You would see this more often in the hospital. Clinically, this includes hospital-acquired infections, febrile neutropenia, severe pneumonia. It is also used for complicated urinary tract infections and intra-abdominal infections, especially when we are worried about resistant gram-negative organisms. Clinical pearl is that cefepime has very strong gram-negative coverage, including Pseudomonas, while maintaining reasonably good gram-positive activity, so it's considered clinically like a big gun when you use this medication. Adverse effects, GI upset, but important one to remember is neurotoxicity in patients with renal impairment. So if the dose is not adjusted for kidney function, patients can develop confusion, encephalopathy, and even seizures. So cefepime is a powerful IV-only antibiotic, typically reserved for severe infections, and renal dosing is critical to keep patients safe. Fifth generation cephalosporins, main agent you want to know is ceftaroline. You may also see ceftobiprole mentioned, but note that it is not FDA approved and is less commonly used, may becoming more common as time goes on. Big high yield point is that these cover MRSA skin infections. So that is what makes fifth generation cephalosporins unique compared to the earlier generations. They are used for community-acquired pneumonia, certain resistant gram-positive infections. Adverse effects, typical of cephalosporins, which is GI upset and rash. There are also some possible hematologic abnormalities with the fifth generation cephalosporin, but these are rare. If you see a cephalosporin that covers MRSA, you're going to be thinking of the fifth generation. Carbapenems, specifically imipenem and meropenem, these are very broad spectrum antibiotics, meaning they cover gram-positive organisms, gram-negative organisms, and anaerobes. So when you hear carbapenems, you think this is a very powerful big gun that we're using. These, because they have extremely broad coverage, their primary use is for resistant infections, situations where other antibiotics are not working or resistance is a major concern. Adverse effects, important one to remember is seizure risk, especially associated with imipenem. This risk is higher in patients with underlying neurologic disease or renal dysfunction. Carbapenems are reserved for severe infections due to resistance concerns. So they are not first-line agents. You want to protect them and keep them, basically preserve their effectiveness by not overusing them. Monobactams, the key drug here is aztreonam. Aztreonam covers gram-negative organisms only. So it does not cover gram-positives and it does not cover anaerobes. Clinically, aztreonam is most useful in penicillin allergic patients, especially when you still need gram-negative coverage. Aztreonam is considered safe in beta-lactam allergy, with one important exception to remember, which is ceftazidime, as they share a similar side chain and can cross-react. So because of that safety profile, aztreonam is useful. It's a useful alternative in patients with anaphylactic penicillin allergy when other beta-lactams are off the table. So big takeaway here is gram-negative coverage only, penicillin allergy friendly, go-to option when severe allergy limits your other choices. Okay, so vancomycin, very important to separate IV use of vancomycin from oral use of vancomycin because they are not interchangeable. So first, IV vancomycin. This is a go-to medication for MRSA infections. So think serious gram-positive infections where MRSA or MRSA is a concern. So things like bacteremia, pneumonia, endocarditis, severe skin and soft tissue infections. Now, the critical distinction is that oral vancomycin is only used for C. difficile infection. Oral vancomycin does not get absorbed systemically, so it does not treat bloodstream or tissue infections. If you give vancomycin by mouth, you are treating C. difficile in the gut only, nothing else. This is a very common exam question and clinical pitfall. Adverse effects, the big one is nephrotoxicity, which is kidney injury, and red man syndrome, which is flushing and hypotension related to rapid IV infusion. That is not a true allergy. What we need to do here is slow the infusion rate to help prevent this. So monitoring with IV vancomycin, we monitor trough levels and renal function. So how much medication is circulating and how are the kidneys responding to assure efficacy and avoid toxicity. So if the question says C. diff, you need to think oral vancomycin. If it says MRSA, you would think of IV vancomycin, but we don't want to mix those two up. Moving on to our protein synthesis inhibitors. So protein synthesis inhibitors, first the macrolides. In this class, we have erythromycin, azithromycin, and clarithromycin. Macrolides are most commonly used for atypical pneumonia. They can also be used for pertussis and chlamydial infections. This is because they have excellent coverage for atypical organisms. Adverse effects, the big one to remember is the QT prolongation. These can also cause GI upset. So always be cautious in patients with cardiac disease or existing QT issues or anyone on QT prolonging medications. Macrolides have important drug interactions. So they inhibit the CYP3A4 pathway, and this can increase levels of other medications metabolized through that pathway. So among the macrolides, azithromycin is the most commonly used, largely because it has fewer drug interactions, better tolerability compared to erythromycin and clarithromycin. Continuing with our protein synthesis inhibitors, clindamycin is another option. In terms of coverage, clindamycin is active against gram-positive organisms and anaerobes. This makes it especially useful when we're worried about infections where anaerobic bacteria play a role. For clinical use, commonly prescribed for cellulitis and dental infections, particularly in patients who have a penicillin allergy or when anaerobic coverage is needed. Major adverse effect to remember is that clindamycin is associated with a C. diff infection. So it carries a high risk of C. diff because it significantly disrupts normal gut flora. This is frequently asked on exams and of course very clinically relevant. So while clindamycin is very effective, we do have to be cautious with our antibiotic stewardship. We want to use it thoughtfully given its strong association with C. difficile. And this slide covers tetracyclines, specifically doxycycline, which is one of the most commonly used agents in this class. Starting with the uses, doxycycline is commonly prescribed for acne, MRSA skin infections, and atypical organisms. That broad coverage makes it very versatile as an outpatient antibiotic. The contraindication that is extremely high yield is that doxycycline should be avoided in pregnancy and in children under 8 years old due to teeth staining and the effect on bone growth. Other adverse effects to remember are photosensitivity, meaning patients burn more easily in the sun when taking this medication and for a period of time after, and GI upset. So patients should be counseled about sun protection when taking this medication. Doxycycline is generally a great oral option for MRSA and atypicals, but always double check, of course, patient age and pregnancy status before prescribing. Okay, so looking at continuing protein synthesis inhibitors, looking at aminoglycosides, specifically gentamicin and tobramycin. These antibiotics are bactericidal against gram-negative organisms, which makes them stand out because most protein synthesis inhibitors are bacteriostatic. Clinically, that is why aminoglycosides are often reserved for serious, life-threatening infections, especially in hospitalized patients. Adverse outcomes to remember are nephrotoxicity and ototoxicity. So that means kidney injury and damage to hearing or balance, and these risks increase with higher doses and longer durations. Because of these toxicities, we have to monitor the drug levels closely. So therapeutic drug monitoring is critical to ensure efficacy and minimizing harm. Aminoglycosides are often used synergistically with other antibiotics. So commonly with beta-lactams in severe infections, beta-lactams help weaken the bacterial cell wall, allowing the aminoglycoside to work more effectively. So very powerful drugs, excellent gram-negative killing, but require careful monitoring. Okay, looking at our nucleic acid inhibitors, fluoroquinolones, sulfonamides, and antivirals. Fluoroquinolones, specifically levofloxacin and ciprofloxacin, these are broad spectrum antibiotics that are commonly used in practice, but they do have some important safety considerations. For uses, fluoroquinolones are often used for urinary tract infections. Levofloxacin in particular is commonly used for pneumonia, including community acquired because it has good respiratory coverage. However, adverse effects are a major reason these drugs are now used more cautiously than they were previously. So one key risk is tendon rupture, especially the Achilles tendon following administration of these antibiotics. QT prolongation, so caution in our cardiac patients, and peripheral neuropathy, which can sometimes be long-lasting or permanent. Because of the effects that are now known about cartilage and connective tissue, we know that fluoroquinolones need to be avoided in pregnancy and in pediatric patients unless there are no other good alternatives. So the FDA basically recommends limiting fluoroquinolones to situations where they're absolutely necessary, such as when a safer antibiotic is not appropriate or has failed. And so just being very cognizant of when we are choosing this therapy. Next up are sulfonamides, most commonly trimethoprim sulfamethoxazole, also known as Bactrim. This is commonly used for MRSA skin infections and urinary tract infections, so you'll see it both in outpatient and inpatient settings. Adverse effects, these are high yield and exam favorites, so things like rash and Stevens-Johnson syndrome, which of course is rare but can be life-threatening. Also need to keep in mind hyperkalemia, especially in patients with renal disease or those on ACE inhibitors or ARBs, as those also have the effect of hyperkalemia. For contraindications, remember sulfa allergy is an absolute contraindication and it should be avoided in pregnancy. Clinical Pearl trimethoprim sulfamethoxazole is prescribed all the time, but its adverse effects are what question writers love. So board exams, you will see questions about the rash, plus the electrolyte abnormalities, or patient with a sulfa allergy. This drug should immediately come to mind. Okay, looking at our antivirals, so shifting away from our antibiotics and onto our antivirals, specifically our herpes and influenza antivirals. Okay, so high-level overview, not all-inclusive. First, our anti-herpetic drugs, Acyclovir, Valacyclovir, and Famciclovir. These are used for HSV and VZV infections like herpes, oral genital herpes, shingles. Valacyclovir is commonly used because of better oral absorption, which we'll talk about. Next are CMV drugs, so cytomegalovirus drugs, Ganciclovir being the key medication, primarily used in immunocompromised patients such as transplant recipients because it does have significant toxicity, so it's reserved for those severe infections. We also have some broad spectrum antivirals like Ribavirin, used less commonly but may appear, as it does have the general antiviral coverage, but it does have significant side effects. And then finally, our anti-influenza medications, so Oseltamivir and Zanamivir. These are neuraminidase inhibitors, most effective when started early, so within 48 hours of symptom onset. Let's look at our high-yield antiviral mechanisms. Remember that antivirals do not kill viruses directly. Instead, they block key steps in viral replication. So one major mechanism is blocking viral DNA polymerase, which prevents DNA viruses like herpes from copying their genome. Others will prevent viral RNA replication, so more critical for the RNA viruses. Some of our antiviruses work earlier or later in the viral cycle by inhibiting viral entry into the cell or release from the cell, thus limiting the spread. And then high-yield concept is the nucleoside analogs. So these act as fake building blocks that get incorporated into the viral DNA or RNA, causing chain termination and stopping the replication. So bottom line is our antivirals target replication machinery and life cycle steps, not the host itself. So this is why the mechanism is not directly killing the virus, but instead blocking replication. A quick high-yield overview of the anti-herpetic agents that you'll see used most common. So Acyclovir is the prototype drug. It works well, but it has the lowest bioavailability, which means patients have to take it more often. Valacyclovir is a prodrug of Acyclovir. It gets absorbed much better, so dosing is less frequent. Because of that, this is typically the go-to option in clinical practice. Famciclovir, very similar to Valacyclovir in effectiveness, but tends to have better GI tolerance for some patients. So Valacyclovir overall is usually preferred because it's easier for patients to take and has better bioavailability. So how do the anti-herpetic drugs work? They are nucleoside analogs, meaning they mimic normal DNA building blocks. Once inside the cell, they need to be phosphorylated by viral thymidine kinase, and that's a key step because only cells infected with the herpes virus can activate the drug efficiently. After activation, the drug inhibits viral DNA polymerase, which prevents the virus from synthesizing new DNA. The end result is chain termination, so viral replication is halted. So the nuance here is because these drugs rely on viral thymidine kinase, they are activated much more in infected cells than in healthy human cells, and that's why they have fewer human cell toxicity compared to many other antivirals. Now, thinking of antiviral resistance, if a herpes virus mutates and loses thymidine kinase, drugs like acyclovir will not work. Okay, what are we actually using these anti-herpetic medications for? Again, main agents are acyclovir, valacyclovir, and famciclovir. First, these drugs are used for HSV1 and HSV2, both primary infections and recurrent outbreaks. So that includes oral and genital herpes. These can also be used against varicella-zoster virus, which is shingles. Early treatment is key here to reduce the severity and the risk of post-herpetic neuralgia. Another important indication is genital herpes suppression. So we give this chronic daily therapy to reduce outbreak frequency and reduce transmission risk. You will also see these medications used for herpes labialis or cold sore, especially in patients that have severe or frequent episodes. And finally, you can use these agents in varicella-zoster virus in immunocompromised patients where infections can be more severe and potentially life-threatening. So two big classes, HSV and VZV, same drug class, same mechanism. Basically, the difference is how we are dosing them based on the virus they're treating. Okay, so our adverse effects with our anti-herpetic agents. Common side effects patients may experience include nausea, diarrhea, and headache. Generally, these are mild and self-limited, but worth counseling patients on so they know what to expect and potentially don't stop the medication. A very high yield and important adverse effect is crystalluria with acyclovir, which is much more common with IV than with oral therapy. So basically what happens is acyclovir precipitates in the renal tubules, and So with acyclovir, hydration is critical, especially for patients receiving IV acyclovir. Always think about IV fluids and renal dosing. Serious adverse effects. There is rare neurotoxicity, particularly in patients with renal impairment. This can present as confusion, tremor, seizures. Adjust the doses. Remember to adjust the dose for renal function and monitor closely in patients with chronic kidney disease. So safety and prescribing precautions with the anti-herpetic agents. Remember, they are primarily cleared by the kidneys. So significant renal impairment is a key concern. If renal function is reduced and the dose is not adjusted, toxicity risk will increase. Dehydration is another important consideration. As we said, these drugs can crystallize in the kidneys, so dehydration raises the risk of nephrotoxicity. Hydration is extremely important, especially higher doses or IV therapy. Interactions, be cautious with other nephrotoxic medications such as NSAIDs or aminoglycosides because they compound the kidney risk injury. Also remember, probenecid can increase acyclovir levels by reducing renal clearance. So these are those drug-drug interactions that we need to be aware of. Next is Ganciclovir and Valganciclovir, which you should think of as CMV drugs. Quickly, CMV is cytomegalovirus, which is a herpes virus that is typically asymptomatic in healthy individuals, but can cause serious disease in immunocompromised patients. So think of transplant recipients, patients with HIV, or neonates. These drugs are not for HSV or varicella. That is a really common exam trap. If the question says CMV, especially in immunocompromised patient, that is where your mind should go to, either Ganciclovir or Valganciclovir. Mechanism-wise, they work the same as acyclovir. They're nucleoside analogs that inhibit viral DNA polymerase, but they are more potent, which is why they're more effective against CMV. The big high-yield adverse effect is bone marrow suppression, so neutropenia and anemia. These patients need to be closely monitored with a CBC for those blood counts. So stronger drugs, higher toxicity, but used when you really need them. So Ribavirin is a very broad spectrum antiviral. It's not something you'll see used very often routinely in practice. Historically, Ribavirin has been used for RSV, especially severe cases, but that's more rare today. It was also used for hepatitis C, but then more modern hepatitis C therapies have replaced it. You'll see it mentioned for certain viral hemorrhagic fevers. Big adverse effect with ribavirin is hemolytic anemia. Hemolytic anemia. Ribavirin can cause red blood cell destruction, so anemia is a classic side effect. And then ribavirin is absolutely contraindicated in pregnancy. It is teratogenic, so it can cause serious fetal harm. One of those drugs where pregnancy is a hard stop. Let's review the medications that we use to treat influenza. The main class we use today is neuraminidase inhibitors. The most common one is Oseltamivir or Tamiflu, which is taken orally. This is the go-to drug in most patients. It works best if it started 48 hours, within 48 hours of symptom onset. Zanamivir is another neuraminidase inhibitor. It is inhaled, so we have to avoid it in patients with asthma and COPD, which we'll talk about on the next slides. These drugs are going to block neuraminidase, and they prevent new viral particles from being released from infected cells, limiting the spread within the body. You may also see Amantadine and Rimantadine, known as the Amantadines, listed historically. These are really not recommended anymore because the influenza viruses has developed almost universal resistance. So our neuraminidase inhibitors are now our first line for flu. Oseltamivir, also known as Tamiflu, again, this is a neuraminidase inhibitor. It does not kill the virus directly. Instead, it prevents newly made flu viruses from being released from infected cells. So that helps stop the infection from spreading to more cells. We can use this for influenza A and influenza B. Timing really matters. It works best if it started with 48 hours of symptom onset. After that window, our benefit is going to drop significantly, but if it's a high-risk patient or very severe, we may still use it after that time period. Most common adverse effect is nausea, which is a real bummer because you already have the flu, especially early in treatment. There are rare neuropsychiatric side effects like confusion and hallucination, often reported more commonly in children. So we can use it for influenza A and B, but we have to start it early and then watch for those side effects. Zanamivir, so our formulation is what matters here. This is an inhaled powder, not an oral medication. So that drives both the limitations that we have and its clinical usefulness. Because it is inhaled, it is contraindicated in asthma and COPD. It can cause bronchospasm, so this would not be a safe choice if a patient has underlying reactive airway disease. In terms of use, zanamivir is our alternative to Tamiflu for treating influenza, particularly when oral therapy isn't an option or perhaps when intolerance to Tamiflu is a concern. So if a patient has influenza, but they have asthma or COPD or another reactive airway disease, zanamivir is a poor choice. So some of our major antiviral players here, just in table form with the route, the key use, and some of the major adverse effects that are reported. So let's move on to safety, contraindication, and some major adverse effects that we want to make sure to keep top of mind. So the really high yield antibiotic adverse effects, fluoroquinolones, tendon rupture, and QT prolongation. So be very aware of cardiac conditions and medications that may already be causing QT prolongation. Tetracyclines, photosensitivity, and tooth discoloration. Macrolides, again, the QT prolongation and GI upset. Clindamycin has the highest risk of C. diff following treatment. Aminoglycosides have the nephrotoxicity and ototoxicity, significantly limiting their use. And then one I want to talk about that we haven't talked about yet is with vancomycin, called red man syndrome. Okay, let's talk about red man syndrome. First, what is it? It is a histamine-mediated infusion reaction. The key point here is that it is not a true allergy, meaning it is not IgE-mediated. In what the symptoms the patient will experience are flushing of the face and neck, also the upper torso. They will feel itchy. In some cases, patients will have hypotension as well, especially if the infusion is very rapid. We know the cause. This reaction happens when the IV is infused too rapidly, and this triggers histamine release. So, of course, management focuses on good training for those doing the IV infusion, slowing things down, slow the infusion rate. You can pre-treat with antihistamines such as diphenhydramine, and then once the symptoms resolve, you can restart the infusion at a slower rate. So some of this is dependent on the patient. This is a very important takeaway, especially for exams. It is not IgE mediated. Vancomycin can still be used as long as it is infused properly. Okay, so overview of some of our very essential antibiotic contraindications. Pregnancy, tetracyclines, fluoroquinolones, and Bactrim in the first and third trimester, and we will talk about how those differ on an upcoming slide. Renal impairment, aminoglycosides, and vancomycin have to be very cautious. QT prolongation, macrolides, and our fluoroquinolones, and then true beta-lactam allergy, which we will talk about more. We want to avoid our penicillins and our cephalosporins. Okay, so what do we mean when we say a true beta-lactam allergy? What actually is it? A true allergy is an IgE-mediated hypersensitivity reaction directly to the penicillin or the cephalosporin. It has a rapid onset, usually within minutes to hours. So a clinical feature that indicates you have a true allergic reaction is urticaria, hives, angioedema, bronchospasm or wheezing, hypotension, or in very severe cases, complete anaphylaxis. And you'll have a pruritic, raised kind of migratory rash. So in contrast to this true allergy we just discussed, we have several reactions to beta-lactams that are not true allergies. So these include GI upset and diarrhea, headache, isolated nausea or vomiting, and non-hive rashes that appear days later, and then also a family history of an allergy in this class. So the key takeaway here is that only IgE-mediated reactions are severe or severe delayed reactions, such as Stevens-Johnson syndrome and TEN, require complete avoidance of the beta-lactam antibiotics. Our other not true allergy reactions listed in red here do not require avoidance of the beta-lactam antibiotics. Okay, let's clarify another important concept. What does it mean when we see pregnancy, trimethoprim, sulfamethoxazole in the first and third trimester listed as a contraindication? So trimethoprim, sulfamethoxazole is avoided in early and late pregnancy for two different reasons. Exams love this distinction. So in the first trimester, the concern is trimethoprim. Trimethoprim inhibits folate metabolism, and folate is critical early in pregnancy for neural tube development. Because of this, first trimester exposure increases the risk of neural tube defects and congenital malformations. So trimethoprim sulfamethoxazole has to be avoided in early pregnancy. In the third trimester, the concern shifts to the sulfonamide component. Sulfonamides can displace bilirubin from albumin in the newborn, which raises the risk of kernicterus. And for that reason, we avoid trimethoprim sulfamethoxazole in late pregnancy. So the key takeaway here is that with Bactrim or trimethoprim sulfamethoxazole, we do not have a blanket pregnancy contraindication. The risk depends on timing. First trimester risk is folate inhibition. Third trimester risk is neonatal hyperbilirubinemia leading to kernicterus. All right, let's look at some of our important drug-drug and drug-food interactions from this presentation. So dairy binds tetracycline. That will decrease the absorption of tetracycline. Do not take tetracycline with dairy. Macrolides inhibit the CYP3A4 pathway. This is going to increase the levels of statins and warfarin if taken with macrolides. Fluoroquinolones have some important electrolyte binding, including calcium, magnesium, and iron. Trimethoprim sulfamethoxazole can increase potassium levels. And acyclovir, when taken with NSAIDs, has that increased risk of nephrotoxicity. So how about our pregnant and lactating women when they come in with infection? What are we avoiding? Our tetracyclines, again, because the teeth and bone effects, the fluoroquinolones because of the cartilage toxicity, aminoglycosides because of ototoxicity risk, and ribavirin, as we said, is teratogenic. Some safe options are penicillins, cephalosporins, and some of our macrolides, particularly azithromycin. Okay, in pediatrics, we are avoiding our tetracyclines in patients under the age of 8. We're going to avoid our fluoroquinolones, but keep in mind that Oseltamivir Tamiflu is safe in patients more than 2 weeks old. For geriatrics, we have to always look at renal dosing and adjust as needed. And keep in mind that with our geriatric patients, we have a higher risk of QT interactions, QT prolongation, or they're being on medications that are going to interact and cause QT prolongation. So the documentation requirements we have talked about in other presentations. These are not different, but there are a few differences I want to point out. So in general, when you write a note on a patient and you are giving antimicrobials, you want to make sure you have justification documented for stewardship efforts. So for example, we want to make sure we are documenting that a patient truly meets the criteria for bacterial sinusitis if we are giving antibiotic for bacterial sinusitis, rather than documenting simply maybe upper respiratory tract infection that could potentially be viral. So anyone reading your note, you want them to understand why you gave the antibiotic. Of course, we're always counseling on side effects and making sure to adhere and take the medication for the full course. Did we have any safety considerations? And of course, our follow-up plan if the patient is not improving. So good documentation looks like this. The diagnosis is an uncomplicated UTI. We are using nitrofurantoin, 100 milligrams PO BID for 5 days. The patient has met the criteria for bacterial cystitis, and that might include documentation of a urinalysis. Counseling was provided for hydration, dysuria relief, return precautions. Allergies have been checked. The patient does not have any allergies, and the patient was informed to call if he or she does not improve in 48 to 72 hours. So I should point out that nitrofurantoin is not one of the medications we discussed in this lecture, but you can see from the good documentation that we had on the previous slide what the indication was for. So Macrolide is the brand name version of nitrofurantoin, but this would be a poor documentation example. So Macrolide for UTI, number 10. So we're missing the dose, the frequency, duration. We do not have indication, counseling. We didn't document that we asked the patients about allergies and we did not give them a follow-up plan. Okay, so when we're trying to make a clinical decision and we're facing infections, either bacterial or viral, we want to identify where the infection is primarily located. This will help us identify the most likely pathogens. Then we're going to select the narrowest effective spectrum for that pathogen. We need to, if possible, confirm local resistance patterns. This is something that your hospital may publish for you, or you may see patterns when you get cultures. And this is very common in UTIs, for example, to see the same resistance patterns and then having to adjust your drug choice based on those patterns. You're going to adjust for any patient allergies, comorbidities, or pregnancy. And then, of course, if we get a culture and it shows that we have we can use a more narrow spectrum, we're going to de-escalate once we get that culture back. Right, essential counseling for antibiotics. This is going to be used, you're going to use this all the time in clinical practice. So patients have to be counseled to take the medication exactly as prescribed, even if they feel better. They should not stop early. Stopping too soon can lead to treatment failure and antibiotic resistance. Patients should be counseled that improvement usually is not immediate. Most antibiotics will take 48 to 72 hours before symptoms noticeably improve. Certain antibiotics have specific counseling points. For example, alcohol should not be used with metronidazole due to the risk of disulfiram-like reaction. Photosensitivity is another important issue. Tetracyclines and fluoroquinolones can increase sensitivity to sunlight, so we have to make sure we are using protective clothing and sunscreen. And then finally, the tetracyclines and fluoroquinolones should not be taken at the same time as dairy products or antacids, since calcium and other cations reduce that absorption. So these need to be separated by several hours. Okay, important counseling points for antivirals. Whenever possible, we start the antivirals as early as possible. So within 48 to 72 hours of symptom onset. Patients have to hydrate well with Acyclovir and Valacyclovir, especially if you give the IV form, you have to think about IV fluids. Herpes suppressive therapy reduces viral shedding. So this is important for viral spread to other individuals, but safe contraceptives should still be used. Influenza antivirals shorten symptoms modestly. So this is not a magic pill, but it can reduce the severity of symptoms by 1 to 2 days. Okay, so as always, we need to address the cultural, social, and literacy factors. So use plain language. Try not to use medical jargon. Say something like, this medication treats the infection that is causing your symptoms. Clear, simple explanations are going to improve understanding and adherence. Written instructions should be very easy to read. Ideally, 5th to 6th grade reading level, short sentences, simple words, clear steps that patients remember what to do once they leave. You need to address concerns about antibiotic overuse. Some patients worry that antibiotics are harmful or unnecessary, so you want to make sure to explain why the medication is needed in situations, in a specific situation, and why finishing the course matters. Assess beliefs about strong medicine. So some patients believe stronger medicine works faster or is always better. This is a good opportunity to explain that we choose the right medicine chosen based on the infection we are treating, not strength alone. And then always try to discuss cost effectiveness. So let patients know that generic medications work the same as brand name medications, but typically cost less. This can reduce some of their financial stress and improve adherence. So some of our common outpatient conditions and their first-line medications, table to review here. So just a summary slide here of some of the monitoring requirements by drug class that we mentioned. Okay, so as we talked about bacterial and viral infections today and how we're treating those, just some red flag symptoms and some overall follow-up recommendations. So always with patients, if there's worsening of a rash or fever or pain or whatever they initially came in with after starting the treatment, they should always follow up. Remember that C. diff risk, so any new severe diarrhea needs to be reported and followed up. Any new neurologic symptoms, we need the patient to report to us. And of course, anaphylaxis, so swelling, breathing difficulty, that needs to go immediately to the emergency room or call 911. And then just remember with herpes zoster near the eye, that is going to be treated a little bit differently from zoster in other areas. That does need an urgent referral to ophthalmology. Just ending here with a few additional comparison tables. So our antibiotic comparison table, and then our antiviral comparison table for you to review, add to, study from.